Hello everybody, Steve Zuckerman in Baton Rouge, and I'm going to give you a brief overview of the latest in terms of migraine management. These all started in 2018 and they've made a huge difference in the ability to control both the number of migraines, the severity of migraines, the duration, and they've been a godsend to many patients. And these, of course, I'm referring to the CGRP, or calcitonin gene-related peptide inhibitors. Now, CGRP is a neurotransmitter which is widely dispersed throughout the body, and it tends to cause vasodilatation. So therefore, it's a cardioprotection agent, antihypertensive, renal protection. It's diffusely throughout the body, doing good things with the exception of the head, in which case it causes migraine headaches. And we would like to stop them. So here is a depiction of the Trigeminovascular system. Now, previously, theories of migraine pathophysiology included only a vascular component, but that is really not an accurate depiction of what happens. What it is thought is that there is some stimulus to the peripheral trigeminal nerve, which then synapses in the nucleus caudalis, and there are receptors in the dural vasculature, and vasodilatation does in fact cause pain, as well as CGRP releasing inflammatory agents from the mast cells. And so CGRP antagonists can block both the signal coming in from the nerve, propagation of that signal by excitatory neurotransmitters from the Trigeminovascular system, as well as inhibiting any vasodilatation. And all of those things are good. So we're going to talk about the various medicines that have been approved and are currently clinically available to either prevent migraines or to treat an acute migraine when it occurs. And all of these molecules and antibodies, monoclonal antibodies, have in common that they are antagonistic, in a nice way, to CGRP. Now, the one big category of migraine prophylactic or preventative is the monoclonal antibody category. 3 of those that are listed here directly attached to the antibody itself, whereas one of them attaches itself to the receptor. So slightly different mechanisms of action, but they're very long acting, and as such very convenient for patient use since they don't require frequent application of that medicine. Now, another type of medicine are called the Gepants, and the top 2 on this list here on the left depict the ones that are currently available, and these are small molecules that pass through the blood-brain barrier to be an inhibitor or blocker of the receptor. And then there's another category called the Ditans that we'll talk about later, which actually is a serotonin agonist at the 5-HT1F receptor, and that is a presynaptic inhibitor of GCRP release. So, now that you have all that useless information, we'll talk a little bit about the physiology. And don't judge me, because I have included a video, which I'm sure will do a lot better than I can do, but it certainly stops this cycle of pain transmission, vasodilatation, inflammation, etc. So here we go.
Migraine is a debilitating disease linked to trigeminal nerve dysfunction. During migraine attacks, calcitonin gene-related peptide, or CGRP, is released by the trigeminal nerve and alters the way the brain processes input. When an action potential propagates along the trigeminal nerve, CGRP is released from both peripheral and central terminals. CGRP then binds to receptors and causes dysfunctional signaling that leads to debilitating symptoms and disrupted daily activities. Let's explore 3 effects of CGRP binding: inflammation, artery dilation, and pain. CGRP binds to receptors on meningeal mast cells and triggers an inflammatory cascade that makes neurons hyperexcitable. CGRP also binds to receptors on smooth muscle cells within artery walls, which causes dilation of intracranial arteries. CGRP binding to receptors in the brainstem increases the firing of postsynaptic neurons, which results in exaggerated pain signals being sent to the brain. Together, these effects lead to hyperexcitable, abnormal brain signaling, which causes multiple symptoms, including severe headache pain.
He took the words right out of my mouth. And so here are the different agents that are currently available to use. I don't like to use the generic name, since I get very confused with all the MABs. So we'll talk about them in brand name as well. So we have eftimizumab, aka Vyepti, which is an IV infusion every 3 months. We have Arenumab, or Aimovig, which is a sub-Q injection once a month, either at 70 or 140 milligram. Fremanezumab, or Ajovy, sub-Q, which can be every month or every 3 months. And galcanezumab, aka Emgality, which is a sub-Q injection, 120 or 240 every month. Now, even though we would like to get our patients on these if we think that they would respond, the insurance companies have a couple of hurdles that they put in our way. And so in order to obtain approval, it depends on the frequency of the patient's headaches. So if they have high frequency headaches, which is 8 to 15 a month, you have to demonstrate or document the lack of success with 2 level A or B migraine preventative medications. If you have low frequency headaches, i.e. 7 or less a month, not only do you have to show lack of success, but you also have to document moderate disability due to the migraines, i.e. they're losing days at work, etc. And then if you're talking about the chronic headache patient, 15 or greater a month, you also have to have tried Botox twice without success. But that's doable. And here, for anybody who's interested, is how closely related these medications were released to the market. So on the top are going to be the monoclonal antibodies, on the bottom the Gepants. And so the first one was Aimovig in May of 2018. Second, Ajovy, only a couple of months later in September of 2018. Emgality was also in September of 2018. Vyepti was in February of 2020, which was about the same time as Ubrelvy and Nurtec ODT, which are the Gepants, which we will talk about next. And here they are, the Gepants. And this category, remember, are the small molecules which block the receptors passing through the blood-brain barrier. And these have been proven to be both effective in the acute as well as a preventative state. They don't have the side effects. They don't have the contraindication of patients who have vascular or coronary artery disease or strokes because they don't cause vasoconstriction. So they can be utilized acutely in the place of where triptans are contraindicated. And again, here's the depiction, and we have 2 on top which are currently available, and it looks like several more are going to be released in the not so distant future. So we have Ubrelvy and Nurtec. I've seen Nurtec used for prevention. It's given every other day. But I think both of them have been approved for that purpose. And then finally, we have another category, the Ditans, which Rayval.
Ditans are a newly recognized class of therapeutic drug that are selective 5-HT1F receptor agonists with a pyridinoyl-piperidine scaffold structure. Lasmiditan is a selective serotonin 1F receptor agonist developed for the acute treatment of migraine. Lasmiditan is considered a first-in-class Ditan based on its unique chemical structure, which features a pyridinoyl-piperidine scaffold, and on its selectivity for the serotonin or 5-HT1F receptor. Lasmiditan's binding affinity is over 440 times more potent for the 5-HT1F receptor than for the 5-HT1B and 1D receptors. Through 5-HT1F receptor agonist binding, lasmiditan can inhibit the release of neuropeptides and neurotransmitters such as calcitonin gene-related peptide or CGRP. In addition, lasmiditan crosses the blood-brain barrier and inhibits migraine pain pathways in the peripheral and central nervous systems without causing vasoconstriction. Overall, this profile suggests that lasmiditan could be a novel therapeutic for treating migraine. A migraine attack involves activation of trigeminal and pain pathways. 5-HT1F receptors are located on neuronal synapses that modulate pain signals in the trigeminovascular and pain signaling systems, including but not limited to the meninges, trigeminal ganglion, trigeminal nucleus caudalis, hypothalamus, thalamus, and cortex. Sustained or repeated activation of these pathways can increase sensitivity of trigeminal neurons in the brainstem that modulate pain signaling. Neuropeptides and neurotransmitters regulate pain during a migraine attack. Nerve activity in the trigeminovascular pain pathway leads to the release of neurochemicals such as CGRP and glutamate. These substances can exacerbate neurogenic inflammation and nociceptor pain signaling in migraine, which in turn may hyperexcite neurons to propagate pain responses and enhance central sensitization. Through descending pathways, inhibitory projections can attenuate pain signaling, likely in part by activating serotonergic receptors, thereby inhibiting local activity and downstream neuronal signaling. However, the pathophysiology of migraine disturbs these modulatory mechanisms, resulting in the characteristic pain that occurs with migraine. A majority of the neurons in the trigeminovascular system are serotonergic, with 5-HT1B, 1D, and 1F receptors shown to be involved in the pathophysiology of migraine. Serotonin receptor agonists are therefore the foundation of many acute treatments for migraine. However, many of these therapeutics are associated with vasoconstriction through activation of serotonin 1B receptors. Unlike many migraine therapeutics, highly lipophilic lasmiditan crosses the blood-brain barrier and presumably acts on the peripheral and central nervous systems to selectively activate 5-HT1F receptors. This activation inhibits the release of neurochemicals such as CGRP and glutamate, inhibiting their local activity and associated pain signaling that occurs with migraine. Preclinical and ex vivo human evidence suggests that lasmiditan inhibits peripheral trigeminal nerve and central nervous system pain signaling pathways, exerting therapeutic effects in the treatment of migraine without causing vasoconstriction, which can occur with triptans. lasmiditan's lack of vasoconstriction is likely due to its lack of activity at the 5-HT1B receptor on blood vessels. These findings suggest that lasmiditan may act through novel mechanisms of action, distinct from those offered by other migraine therapies. As such, lasmiditan may be beneficial for patients who have an inadequate response, contraindication, or intolerability to other migraine therapeutics.
I'd like to thank everybody for tuning in and listening, and hope you can use this information in treating patients. Thank you.